Actually started our stream.
Oh, you haven't. Oh,
there.
you
All
haven't
right.
started. All
I
right.
guess I should call this meeting of the Health Occupation Subcommittee to order. We have a lengthy agenda. We would like to get to all of our bills before the 1 o'clock full committee hearing. We're going to begin with House Bill 377 first on the list. Physician assistants, parity with other healthcare practitioners. Delegate Johnson.
Thank you, Mr. Chair. There was an amendment put on the bill after meeting with the psychiatrist. The amendment requires the MHA to keep track of when a person comes into a hospital, the time they arrive until the time that they either get admitted or transferred, and they will report back to the committee by December 1st, around that time. So we will have some real data on exactly what the wait times are in the ED for admissions. We also are sending a letter to the Hospital Association to ask them to put, right now when you pull an admission form, it gives you 3 choices of people who are authorized as a signatory on admission. But there are by law 2 other people that are authorized. We ask them to change their admission forms to include the 2 other people who are by law authorized to sign the admissions.
If I could clarify real quick, while the data would actually in practice be collected by the hospitals, it would be sent to MHCC, who's collecting that data and reporting back to the General Assembly on that data.
That is correct. Thank you, Lindsay.
Okay. Is there any discussion on the delegate's amendment? Is there a motion on the delegate's amendment?
Motion to move the amendment.
So moved. Is there a second?
Second.
And seconded. All those in favor of the amendment say aye. Anyone opposed?
Aye.
No one is opposed. Is there a motion on the bill as amended? Delegate Riley, your hand is raised.
Yep, I just was aye.
Okay, thank you. Is there a motion on the bill as amended? We now have a quorum. Delegate Tavares is here.
I just want to make sure that we're on 377.
Yes, we are.
Okay, aye.
The motion is on the bill as amended. All those in favor, please say aye.
Aye.
Anyone opposed?
I just had a question before we.
Certainly.
Okay. Delegate Johnson, we had quite a few amendment suggestions from MedChi. Did they all get put into this bill?
No, we removed the involuntary admission part of the bill, and MedChi after that point was okay with the bill.
Okay. All right. Thank you. Looks like there might be another question.
Mr. Altieri?
Yes, good afternoon. Thank you, Mr. Chair, members of the subcommittee. My name is Gabe Altieri with Harris Jones Malone on behalf of the Maryland Psychiatric Society. At first, I want to say I appreciate Delegate Johnson spending time sitting down with us to chat about our concerns. And I've got Dr. Lewis with the Psychiatric Society here as well. And I just want to make clear, I appreciate Delegate Johnson's efforts to remediate some of our concerns, but we still do have significant concerns with the inclusion of PAs in Health General 10-600 and really that whole section, which deals with things that traditionally a physician or an NP, a psychiatric nurse practitioner, would be responsible for undertaking.
Thank you for bringing that up.
Any further discussion, Delegate Zaliga?
Thank you. Gabe, were there any amendments that could address that? I mean, if nurse practitioners are afforded that privilege, would there be some narrowing language that could help ensure that physician assistants that have the proper training are included?
I think, and I'd love to hear Dr. Lewis's opinion on this. I think that it's difficult to, at this stage in the process, to identify what an appropriate level of training would be to put into a bill with 42 days left in session. And our suggested amendment would be to strike the 10-600 from this bill.
And I'm in a position now, I've been able to find a parking space. I can speak to the concerns if needed.
Okay. Delegate, well, Mr. Varghese.
Good afternoon. Yes, OPD would still be in opposition to the sections of the bills that relates to Health General 600. That includes the involuntary as well as the voluntary admissions. Our concern is that voluntary admissions are now allowed for individuals who are under guardianship. These are individuals who have already have a court order showing that they have limited capacity to make decisions. The voluntary guardianship, we want to make sure that individuals who are under guardianship are appropriately being evaluated as to their capacity to be a voluntary. Because, for example, either that would prevent them from coming in as a voluntary and then forcing them to be potentially an involuntary, where they risk collateral consequences for that. We would ask that as the previous opponent of that section of the bill testified to, we would ask that be struck as well.
The sponsor of the bill wish to comment? Delegate Johnson.
Mr. Chair, I'm going to let Robin Elliott address that if you wouldn't mind, please.
Certainly. Robin Elliott.
Sure. Robin Elliott on behalf of the physician assistants. We would ask that voluntary admissions be kept in the bill. This really didn't come up at the bill hearing. These are voluntary admissions. Hospitals have a process in place whereby they make sure that anybody, including PAs, physicians, NPs, this whole range of providers who are working in hospitals are qualified to do what they're asked to do in the hospital, whether it is in this instance, in the OR, in the ICU. This is a real process problem. We do not want people to have to wait for these admissions if there is not a secondary signature available. And there are often PAs available in these settings who have lots of experience on this area, and we would ask for this to remain in.
Okay, so the bill sponsor would oppose the amendment, obviously.
Yes, Mr. Chair.
Okay. Ms. Lewis?
Yes, hi, I'm Dr. Lewis. I'm the director of the Psychiatric Emergency Services at Johns Hopkins. I just wanted to again reiterate, I'm also co-chair of the Legislative Committee for the Maryland Psychiatric Society. Our concern, even with the voluntary admissions, is that in order to offer someone a voluntary admission, they have to be evaluated by a mental health professional. And if someone is willing to come into the hospital, then we give them that opportunity. But there is a chance that that voluntary admission can turn into an involuntary admission. Also, we, as an emergency psychiatrist, I worry more for the patients that we discharge as opposed to the ones we allow to come in. So in order to evaluate someone for a psychiatric admission, it requires a mental health evaluation. It's not the same evaluation that you give to someone who comes into a clinic or a facility. It's a mental health evaluation. The person who often signs the voluntary is the person who did that mental health evaluation. There's involuntary commitment law. There are, suicide risk assessments. There are many tools that we have to use our many years of training to determine.
Can you check over to Alonzo's office and see if he'll do a meeting? Thank you.
So I remain concerned as a psychiatrist. The Maryland Psychiatric Society we do not support anything that allows PAs to operate in the mental health space in that nature. It's our understanding that PAs operate under the license of a physician. So we would still want that physician who has the training that's appropriate to sign off on these kind of forms, because there are many consequences that could be life-threatening if someone's not evaluated appropriately. And we do not believe that PAs currently have the correct mental health training to sign off on these
Thank
matters.
you. Thank you. Delegate Cullison.
Thank you, Mr. Chair, for allowing me to interlope here. My concern around the involuntary transfer issue is these are folks who are seeking help. They have already acknowledged that they need help. And I know that there's going to be an assessment of them, but I suspect that most of the time, if they are coming in seeking help, they they're not going to be discharged. They're not going to be turned away. And I can't imagine, unless if they ask for help and they are, it's determined that there's a placement for them to get this help, they have a choice of making sure if they want to go or if they don't, because they've come in as an involuntary. The only way that they would be turned into, they came in as voluntary. The only way that I can see, and if the doctors can explain to me why it's different, that they would be involuntary if in the process of the assessment, the severity was significant. So but at the same time, if we give them help as an involuntary, they will get the help that they need ultimately, and it wouldn't have to be involuntary. So I'm hoping that the involuntary part of the bill can stay as it is. Thank you, Mr. Chair.
Delegate Johnson, sponsor of the bill.
Thank you, Mr. Chair. The involuntary part was taken out of the bill. So if a voluntary admission turns into an involuntary, they would not be signing for that anyways.
So there is no amendment. The amendment is not relevant then or appropriate.
No, because the involuntary admission was taken out of the bill.
By an amendment that you have offered and we have accepted?
That's correct.
Yeah, if I could just clarify, you all had actually already voted this bill out of subcommittee with the amendments that removed from the bill provisions relating to involuntary admissions. The amendment before the subcommittee now is the one with the MHCC data gathering and report back.
Offered by the sponsor of the bill.
Yep.
Okay. And we have approved that amendment. Now what's before us is the bill as amended by that amendment and prior amendments that we have adopted. Delegate Tavares, you are recognized. Delegate Tavares, you've frozen on my screen.
Thank you. I understand that I dropped out, able to hear better.
We can hear you better now.
Is that
Yes.
better? Okay.
Yes.
All right. So my concern is that I'm hearing that there is a hesitancy in allowing physicians' assistants to be within these spaces where they already prescribe, where they're already with psych, where they're already with the patients. And if training is such a concern, why are they allowed to prescribe and do all the things that they actually do now? What is, I'm confused, because I am like nurse practitioners, they're able to prescribe, like I see nurse practitioners are very close to providing almost the equivalent of my doctor's care. Like, I don't understand what the hesitancy is. And especially in light of this, when it is voluntary on the individuals going in.
Sponsor of the bill wish to respond?
Thank you, Mr. Chair. Delegate Taveras, I think the sticking point in the bill is for being the second signatory on an admission. And I think that's the discussion we're having at the moment.
Again, my point is that they already do everything else. What's the issue?
That's a good question, Delegate. We don't think there is an issue since a physician has to be one of the signatures. So we don't think there is an issue. So that's why we're trying to move the bill.
Okay.
And this would, who would be able to sign in addition to the required physician? Is that correct?
That is correct.
Delegate Saliga. Your hand is
Thank
still
you. I
raised.
was hoping we could hear from Dr. Yes, I was hoping we could hear from Dr. Lewis. She seems to have something else to add to the conversation.
Okay, briefly, because you have spoken already.
Yes, I just wanted to emphasize that it is not as simple as it seems. PAs do not get the mental health training. Psychiatric nurse practitioners go through 2 years of study focused on psychiatry. In some states, they have to work alongside a psychiatrist. In Maryland, they do not. But they do get the mental health training that now allows them to sign off on involuntary certificates, to do mental health evaluations, to determine if someone is going to be admitted or not. I did want to emphasize that when someone comes into the hospital, to the emergency department or a crisis facility requesting inpatient admission, they have to be evaluated. The majority of people I see, probably 85%, want to come in, but most of them get discharged because to determine the risk assessment and if an admission is appropriate. If someone is involuntary, by definition of them being involuntary, means they do not want to be there. I think we've already settled that part, but a voluntary admission are the ones that keep me up at night, because the ones that I send home after they've presented with suicidal thinking and other concerns, I have to, with my level of expertise, psychiatric nurse practitioners, it's not the same that I get, but we've been able to work with the education that they've received. But they're the ones who are the scariest, because we are letting them go home. And the ones that want to come in sometimes aren't appropriate to come in. The ones that want to come home, but people are bringing them there or do not want to come in, we have to make adequate risk assessments using all of our training from a mental health space. This is very unsafe to think that just signing off because of access and wait times, and there's other reasons that wait times are a problem. It's the bed status, it's the nursing shortages on the units, where the acuity, it's not the ability for people to be seen. People can be seen by social workers in the emergency department, by psychiatric nurse practitioners, by the ED physicians, or there's got to be a mental health trained person. So I just want to emphasize that it's not as simple as signing off and decreasing wait times. It's so much more than that.
Okay, thank you. Delegate Lopez.
Thank you, Mr. Chair. I asked this question in a previous subcommittee meeting and kind of did some research on my own, but I think it would be good to ask the sponsor of the bill, Delegate Johnson, this question too. Can you tell us where the behavioral health groups are on this bill, and if they support it in the areas where they do or they don't?
You're muted, Delegate Johnson.
Sorry, Mr. Chair.
That's okay.
We had one opposition originally, and that was MedChi. We took the involuntary admission out of the bill. That satisfied MedChi. They were okay with the rest of the bill. Other than that, we had no opposition until at the very end of the subcommittee meeting, when the psychiatrist came in and had some opposition. I met with them, took a few of their concerns into consideration. And again, Dr. Lewis talked about involuntary admissions. We took that out of the bill.
Gotcha. Can I have indulge me in a follow-up, Mr. Chair?
Certainly.
Thank you. Delegate Johnson, I just want to make sure I'm clear about this. So the behavioral health groups have not opposed this with the original form or the amended form. They're okay with this.
That's correct.
Okay.
Crystal Williams.
Thank you. I just wanted to offer some additional clarification to Delegate Tavares' question and some additional comments that were made about
And you are here on behalf of?
Oh, my apologies. The Office of the Public Defender. And so our position has been that we were opposed to the involuntary language, which we are thankful for Delegate Johnson's amendment to remove that. However, as Mr. Varghese mentioned, we also had asked that the voluntary admission portion be out as well as the emergency petition. And most importantly, our concern is that the voluntary criteria certainly does implicate a person's liberty when you are deciding whether to classify someone as voluntary or involuntary. That is a determination of their liberty rights. It also absolutely affects their legal rights. There are different legal rights that are implicated based on a voluntary status or an involuntary status. Oftentimes, patients are changed throughout their hospital stay from voluntary to involuntary or vice versa. And once they are classified as a voluntary, that removes their counsel, right to counsel, as well as their right to have an administrative court proceeding. So there certainly are legal implications, liberty implications in terms of their voluntary status as well. So I just wanted to clarify that and offer that information. Thank you.
Robin Elliott.
Thank you. Just wanted to add upon what the bill sponsor said. There were a couple of behavioral health consumer advocacy groups that came in at strong support of the bill as introduced. That was NAMI and the Baltimore Behavioral Health System, as well as the Maryland Rural Health Association. So just wanted to provide that background.
Do they support, to your knowledge, the bill is amended?
They supported all the parts of the bill, so I think they would support all the remaining parts that you've left in with the proposed amendments.
Okay. I hesitate to keep this going because we have other bills as well. I'm going to move the vote. The motion is on the bill as amended. All those who are members of the subcommittee, please raise your hand electronically. I'm going to do that too. Hold on. All right, there are 3 in favor. All those opposed to the bill, please raise your hand. No, it is a tie, 3 and 3. So hold on, Delegate Tavares, how are you voting or not voting? Delegate Tavares, your hand was up and now it's down.
I'm a 4.
You're for the bill.
Yes.
So the bill passes 4-2. Okay. We will move on to House Bill 520, State Board of Physicians, Naturopathic Doctors, Scope of Practice, Renewals and Professional Liability Insurance. Delegate Cullison is the sponsor. Do you wish to say anything or describe the status of the bill? Are there amendments?
There are no amendments to the bill. And I guess I would ask the subcommittee to reflect back on the hearing for the bill, where it was clear that the level of pharmacological training that naturopathic doctors have is equal to other licensed professionals that we have in Maryland who have full prescription authority. We have included in the bill a formulary to control for controlled dangerous substances, which I think was something that MedChi was very interested in. And I think too, it's important to understand in the hearing, the issue was raised that naturopathic doctors have a different view of medicine than Western doctors, and that's true. One of the things that naturopathic doctors do differently is they look at the whole person and look at all of the systems as they work together. And they look for, options for treatment. And pharmaceuticals are not always going to be their first inclination, but for their patients where they see the need for pharmaceutical drugs to treat something which was within the scope of their practice. And I'd say to you, and this is recognized nationally, the scope of their practice is essentially that of a general practitioner or a primary care doctor. It's it's virtually the same scope. And so, and there have not been any issues around in the states where they have full prescribing authority. And we haven't had any issues with naturopathic doctors in Maryland, or very few. The only time there have been complaints against naturopathic doctors, according to the Board of Physicians, are those who are practicing without a license. So I think, in order to expand access to folks who are who act in a general practitioner primary care position, and that people have that choice to go to, that I hope that we can pass this bill. Thank you very much for the time, Mr. Chair.
Thank you. Are there any comments from subcommittee members? Delegate Zaliga?
Thank you so much. So do nurse practitioners prescribe right away when they're licensed?
Yes.
They do?
Yes.
And are they prescribing opioids?
It's within their scope. So if they are within a if their license includes the treatment for things that might need opioids, yes, they can prescribe opioids.
So they don't do an 18-month period with a mentor?
It exists, but it's not, they don't have any kind of written agreement or anything. It's just
it's a handshake?
Yeah, it's a handshake, basically. Yeah, that's my understanding.
Okay, I'll defer to Steve Wise, who may have the rest of the story.
Mr. Wise?
Thank you, Mr. Chairman, and Delegate Collison as well. Just to respond to a couple things, and I'm not going to go on because I know this bill has been well debated by the committee, and you've heard from me before on it. But we just have a fundamental difference of opinion here on the basic training of a naturopathic doctor versus an MD or DO. Namely, that the MD or DO does a significant residency. A lot of that is understanding prescribing. I know the response to that, which is what Delegate Carlson alluded to, is that, well, nurse practitioners don't do a residency, but they're allowed to prescribe. And really, this is parallel to that. I would respond to that just by saying the basic underpinnings of naturopathic medicine are different from what a nurse practitioner and a doctor undergo. It's allopathic medicine versus naturopathic medicine. And all you have to do is read the definitions in the naturopathic law to understand what it's founded in. If it was the same, we wouldn't have needed a separate licensure, separate educational structure, separate accrediting bodies. So there are basic differences, and we think those make a difference as to whether or not they prescribe. When this law was first passed 14 years ago, however long it was designed to be an alternative offering to supplement, if you would, to complement traditional medicine. And if this bill passes, I think you've effectively made it the same because they will have the same authorities. And I'll just refer you back to the med student and the third-year resident who testified. You know, I'm not sure what the incentive is for somebody to do a residency and go to medical school when somebody who doesn't do those things is being given the exact same authority. So I'll leave it at that. Thank you.
Madam Vice Chair, briefly, since you've spoken already.
Thank you, Mr. Chair. And just really quickly, yes, they are different, but I still believe they're complementary. Even if this passes, they're still complementary, and there are agreements between allopathic doctors and naturopathic doctors, and they do work together. And you heard testimony to that fact. So that's all I'll say for now, Mr. Chair. Thank you.
Delegate Saliga.
Sorry for one more bite at the apple, or thank you. You know, I love this little wheel that we've been given that talks about training. So a physician has 4 years of graduate education. They do 3 to 7 years of residency fellowship, and they have 2,000 to 16,000 hours. We're a naturopath, which I think are wonderful, and you know, drop my paper, are, you know, serve certainly a role, but the naturopath has 4 years of graduate level education, and they are not required any residency or fellowship, and they have 850 to 1,200 hours of total patient hours. I just am very concerned because we have an opioid problem. And, you know, we've really dealt with that within the medical community and prescribing and overprescribing. And furthermore, I think, you know, it in some ways diminishes all the training, and it ultimately becomes a patient safety issue. So for those reasons, I'll be voting no.
Robin Elliott.
Thank you. Just wanted to thank you for the questions around opioids. Robin Elliott on behalf of the naturopathic doctors. Just wanted to share some background on how the bill is structured. So the bill would provide prescriptive authority for non-controlled dangerous substances. So those are the kind of more everyday medications. Like for hypertension and things like that. I think you all heard some examples. For controlled dangerous substances, first, the bill does not allow at all naturopathic doctors to prescribe Schedule IIs, which are where the opioids are. And then for Schedule 3 through 5, they may prescribe from a formulary that has to be approved by the Board of Physicians. So what we're anticipating is that is actually quite narrow. So there won't be any opioid prescribing under this legislation at all. Thanks so much.
Delegate White Holland.
Yes, Mr. Chair, I move the bill.
Okay, the bill is moved with, were there any amendments? No, there are no amendments. Okay, the motion is on the bill as introduced. All those in favor, please indicate with your electronic hand. Okay. There are 5 in favor. Thank you. Please put your hands down. All those opposed? 5 to 2. Okay, the bill moves forward. House Bill 508, physicians licensing internationally trained physicians. Delegate Hill, my understanding is we're working on amendments.
Oh, I think we have the basic amendments, and I'd like to go ahead and present them. And if there are any discrepancies, we can work those out and come back to the next. But I think we've pretty much got it where it needs to be. And I want to compliment Ms. Rowe for pulling together desperate pieces to something that actually falls into place. So we've incorporated, I'll start with the simplest amendment. MedChi had requested an amendment to make sure that as the process, as the board rolls it out, that the physicians in Maryland are consulted about it through MedChi. We had the board's amendments, which both tried to address through this bill issues with the imminent or conceded imminence structure, and they wanted to be sure that the physicians who came in through this pathway, they wanted them to be supervised through a widely defined group of medical programs. And so we've done that. At the same time, we wanted to be sure that there was also an alternative pathway for physicians. And so be supervised, meaning they wanted them to be tied to an employment. But the work group had also wanted to make sure that there was a pathway for folks who weren't necessarily tied to a pre-existing offer of employment, and therefore would not have a clear line of supervision for the first 3 years. And so we've created that as an alternative pathway too. And the institutions of medical education wanted to be sure that they had increased ability to compete for the physicians that they needed with the surrounding states by removing requirements that they take the third step of the board. And they also asked that the limited license be extended or be able to be extended one time. We've not accepted that request. Anyway, so if with that being said, I think we've taken the essence of it, and the also agreement was that we received a letter from Mr. Altieber indicating that at my request, the educational institution, University of Maryland School of Medicine, and medical systems, Hopkins, and a number of the other teaching hospitals have agreed to put together an examination that could be administered at the end or in some cases earlier on to determine that the physicians who are being either granted this limited license or being considered for licensure based on their international experience and training can comply with the standards of care and practice that we expect every physician in Maryland to follow. So they've agreed to create that evaluation structure. And with that, I would ask that that Ms. Rowe go over the amendments that we're offering.
Council, please, can you describe the amendments that are before us?
Sure. I think Delegate Hill actually just did a pretty good job of describing them, but
Okay.
so the reprint that was sent out, the first thing that's happening is the amendments repeal the fifth pathway program, which is an exemption to the education requirements for folks who are U.S. citizens but who go to international medical schools. It's repealed, and then this new pathway is put into place. There are some conforming changes, removing references to Puerto Rico where they appear in other provisions of law because it is a territory of the United States. And so that's already covered when it says United States, its territories or possessions or Canada. I will note about 2/3 of the way down page 2, I noticed there is an amendment drafting error here, that there's some amendment directional language that's appearing in this draft. So I apologize. I will figure out how to fix that. But that's where above line 16, there's a reference to line 16 there. That's going to have to come out. The license that's being created is retermed a limited license that's issued by the board, again, not to exceed 3 years, and as Delegate Hill said, may not be renewed. Then the bulk of the changes are clarifying the qualifications for licensure. Let's see, if you are on what's actually the third page of the reprint, but at the top of the page says bill page 2 of 3. About 2/3 of the way down is the description of a state standard of care assessment approved by the board, which includes components testing patient safety, state standards of practice, and English language proficiency. That is the exam that Delegate Hill was just referencing, that she's gotten some hospitals to agree to put that together. That reference, I believe, is going to need to be added in another location because Delegate Hill just described an alternative pathway for someone who's not been offered an offer of employment, and these were drafted. I think there's just the one requirement that someone have an offer of employment from a healthcare facility that will evaluate the physician's non-clinical skills and familiarity with standards appropriate for a medical practice in the state. So we're going to have to bifurcate that to clarify to a second scenario where someone does not have that offer of employment. And then it provides for a holder of a limited license to apply for full licensure after they've submitted proof of successful completion of the healthcare facilities evaluation and achievement of a passing score on step 3 of the U.S. medical licensing exam. And then again, as Delegate Hill already mentioned on the last page, there's a special section clarifying the intent of the General Assembly that the board consult with MedChi on the development of policies and regulations.
Is there discussion on the amendments? Delegate White Holland.
Thank you, Mr. Chair. I just wanted to inquire if there is, based on the discussion, and Dr. Delegate Hill, you've done an outstanding job in bringing everyone together and going through this, but I wanted to know if there is any further outstanding unreadiness or concerns, just to ensure that that regardless of the pathway, that it is still on par with our current physicians. Just wanted to kind of get a sense of where we are with that. And it's possible that in your description, you and your and Lindsay's description, that it was covered. So my apologies for any repetition, but I just wanted to get a sense of if it has addressed all of the outstanding concerns.
Right. So let me explain where we think we've addressed those. And again, this amendment, which still has a few changes that we need to straighten out, just got out to the stakeholders today. All right. So we'll need to go over that. So the way we're addressing is, number one, they have to pass. First of all, this can only be done for people who have graduated from programs and practice in countries where the board is comfortable that the board is able to assess that they're essentially equivalent. So if it doesn't follow under that category, if it's the state of you know, somewhere that we've never heard of, and the board says, I don't know the quality of their programs, I don't know the quality of their licensure, they automatically don't qualify under this system. We understand, as was stated during testimony, that there is no entity right now that makes those determinations, but there are groups that are looking to do that. And the board can limit it to, again, the countries that they're comfortable that they can check on those credentials and verify them. And that may change. So for instance, it may be that, you know, Ukraine would be considered somewhere that they felt like we know the quality of someone from Ukraine, and then Ukraine gets involved in a war and folks come over and they can't verify anymore who had a license or who didn't have a license. So it might be that we used to be able to approve physicians who came here from Ukraine, but we could no longer do that, right? So it gives the board the flexibility to decide what countries it's comfortable saying we can verify your licensure and your training, and which countries they can't. So that's number one. Second of all, when we talk about that they have—
if I can interrupt, you're describing the amendments as submitted to—
I'm answering Delegate White Holland's question about how do we assure that the quality, that the expectations for these practitioners are at least as the same that we would have through practitioners who are trained in America, come through our residency program, et cetera. That's the question, correct? So
That's the question, yes.
right, and when they have to pass, we have in here the ACGME. That's the first level of testing that American graduates have to pass as well. Where there was some stipulations, a third step that what we got from the stakeholders was that's a really difficult step to ask someone who's been out of training a long time to do. And so a slight change to the amendment before you is when we talk about if you apply for this limited license and you are being employed by, say, an academic institution, a medical academic institution, that at the end of that 3 years, what the amendment says is that you then have to pass the step 3. Folks didn't think that should be the standard, so what we want to add, or you pass that state standard of care exam that is being developed. Okay, so that's what we want to add, that there is a state standard of care exam that does not exist now, that will exist. And if they can pass that state standard of care exam, they can go on to that permanent license. So those are how we're trying to make sure that the quality is the same, if that answers your question.
Okay, thank you, Mr. Tran. Thank you, Delegate. You're
Thank you,
muted.
Chair Rosenberg.
Okay.
And thank you, Delegate Hill and Council for kind of putting those amendments together and getting them to us. Like Delegate Hill said, we just got them this morning, so we're gonna have to review together answer to you just or just to ask for clarification here. Does the amendment now allow for it strikes the USMLE 3 testing for this limited license, but does that still include the ECFMG certification for all applicants across the board to enter any pathway? Does that include the USMLE 1, USMLE 2? And so that would be the certification, right? I think the current language is recognized, but we would just want to make sure that
explicitly
it's the certification. It's that the certification is issued and not just a program recognized by ECFMG.
Fine. Lindsay, does that make sense to you?
I apologize. It does not. It does not make sense to me.
So they
But
have to
maybe
pass.
I
Go
realize
ahead.
it's about 3 minutes till bill hearings. Maybe when we're
Well-
revising these amendments, Michael can
Okay.
suggest specific language to address it.
Okay.
Absolutely.
And I'll pass on, they've given us language and I'll pass that piece on again and show you where it is. Okay. And I think the other bill, the amendment that we did not take up, as I said, Mr. T. Rickman speak to, they asked that the limited license be able to be renewed once to be up to 6 years. And they're talking specifically about the people who are under, who are basically under a teaching program. And again, what we did not want to do was create another residency, right? Or create a system where, because say the University of Maryland has hired them, that they're stuck serving them as resident-like, less physicians for 6 years. We don't want to create sort of an indentured servitude thing. So if you can't pass with 3 years, then you don't go on to get a permanent license. And that's the main reason we did not accept that request for an amendment.
Okay. Are we a dead stop at 1 o'clock, Council, or what? Do you know?
I believe bill hearings are supposed to start at 1.
Okay. Well, let's work down this list. Mr. Tilburg?
Yeah, thank you, Mr. Chair. Will Tilburg on behalf of the University of Maryland Medical System, and thank you again, Delegate Hill, for working with us on this bill. The bill is, as initially drafted, did not contemplate conceded eminence, so we're appreciative of that work. I think you addressed, Delegate Hill, a lot of what our outstanding concerns were with your last statement related to USMLE 3. In the stakeholder meeting that we had, Dr. Regine from the School of Medicine was stressing that USMLE 1, 2, or 3 are not appropriate for long-time serving international physicians, and that if we were developing an internal evaluation that should be adequate for practice. And it sounds like that's what's being incorporated moving forward. And so we're appreciative for that. There's one technical piece in C6. It references you have to have an offer of employment from a healthcare facility. Schools of medicine don't technically qualify as that. So we would just ask that there, potentially a friendly amendment for schools of medicine or NIH be added to that. Otherwise, what we see on the page and Delegate Hill, what you just described, I think addresses our concerns and would actually enable Maryland to be able to compete with surrounding states that have streamlined the conceded eminence process.
Delegate Zaliga.
Sorry, I was looking for the right button.
Okay.
Should we just continue this conversation as it is 1 o'clock and we need to get to committee? Can I move that we adjourn and pick this up later?
Mr. Chair, if you have the seconds to just hear what the other people have to, obviously it'll have to come back, but if you wanted to hear what they had to say and we have the time, if we don't have the time, we don't have the time, I would ask.
Apparently we don't have the time if we're going to start at 1 o'clock. So we will, there is a motion to adjourn. All those in favor say aye.
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 Anyone opposed to adjourning? Okay, we stand adjourned. We will meet soon. Thank you.
Okay. Does this